Welcome. This is a subsequent segment to initiating APRV. So we'll talk about titrating APRV or airway pressure release ventilation. We'll focus on oxygenation, which is dictated by the P high or the pressure high, followed by T high or the time at pressure high. The next thing we'll focus on is the carbon dioxide level or PCO2 levels using the T low along with the respiratory rate or the spontaneous respiratory rate in some of these patients. So after initiating APRV, you get the ABG back and you notice that the PaO2 FiO2 ratio is still less than 100. What now? So what you want to do is optimize the two settings that really play a role in oxygenation. One is going up on the P high and optimizing T high. So what you can do is for P high, you can go up to a value of 35 and maybe even higher. There may be some evidence, at least in patients who are morbidly obese, going up to a higher value than that. Especially if you started off at a value of 30, you may go up to 32, followed by 35. The next thing to do is T high. If you started off with a default setting of 5.5 seconds, you can go up to a value of 6 seconds. This optimizes the amount of time the lungs are recruited and expanded to allow and facilitate oxygenation. The other thing that we tend to lose track of as well, and these patients are extremely sick, is that we have maintenance fluids going and we have boluses due to the patient's shock. We have patients going with maintenance, sedation, medications and so on. So that adds to the positive fluid balance in all these patients. And initially, if they started off having ARDS, the ARDS may be in the background, but now it is pulmonary edema, which then ends up playing a role in these patients, especially if they start experiencing acute kidney injury and anuria and the urine output is poor, or if the urine output is fine and they continue to get dumped on a whole bunch of fluids. So be cautious of that as well. So take note of the fluid balance, especially when you're finding that oxygenation is a difficult endeavor and you're hitting a brick wall. The next thing we'll talk about is the maintenance of PCO2. Now, the idea is in patients with APRV is to allow something called permissive hypercapnia, and this is something we came across during the ARDS network trials. Because of the compliance of the lung, we're giving up one for the other. So in terms of when we optimize the oxygenation, we're trying to recruit the lungs and keep them open as long as possible. So de-recruitment and decompressing the lungs to allow CO2 to be washed out compromises the oxygenation. So we do allow some level of permissive hypercapnia. Now just be cautious as well, especially in pH levels less than 7.2. This is a situation you really want to avoid, especially in patients who are hemodynamically unstable, on vasopressors and so on. You want to minimize the pH value to at least keep it above 7.20. So while permissive hypercapnia is acceptable, just be cautious as well to maintain the pH, and don't give them boluses of bicarbonate or IV bicarb pushes, because that will convert to CO2 eventually and increase that burden. So how do you maintain PCO2? You maintain PCO2 by doing two things. One is you minimize sedation. The beauty of APRV is to allow, and the patients at P high, is to actually allow spontaneous breaths at P high. So you want to minimize sedation, allow patients to breathe on their own. Just be cautious as well about some of the pressure support that is given during these additional spontaneous breaths. You want to make sure that the tidal volumes are within 6 cc's per kilogram, and you don't over distend these lungs, because this is already a P high, right? So they're P high of 30, and then they're taking breaths of it on top of that. So you want to make sure not to over distend the lungs. So take note of the tidal volumes during the spontaneous breaths. So first thing to do, like I said, to maintain PCO2 is actually to minimize sedation. That's the beauty of APRV, is to allow spontaneous breaths. The next thing you can do is to increase the time low. So T low can be increased. So example, if you start off at 0.6 seconds, you can transition to 0.8 seconds and allow more time at T low, so it decompresses the lung a little bit more and washes out more CO2. So you can either minimize sedation, or you can go up on your T low and try to get that. Now, you don't want to. The other thing you can do is go down on the T high, but if oxygenation is an issue, you're going to try to avoid that. Don't do these two things at the same time, unless, of course, you have significant acidosis and you need to reverse that quickly. you want to do one at a time and see what the level ends up being, or what the PCO2 level ends up being, and then initiate. So start off with this and minimize sedation, and then go on to reducing T high, for example, from 6 seconds or 0.6 seconds to a value of maybe 5.5 seconds. So once you have all of that, you've made your changes and so on, in APRV, because the changes, especially with the PCO2, the decompression of the lung occurs every 6 seconds, it does take a while for a baseline or a maintenance value to occur. So get the ABG. I normally get mine about an hour to 2 hours after, and the oxygen saturation monitor, the pulse ox is reasonable. I'm in no rush, and I know that it's going to take time for the CO2 to get washed out if that's what I was dealing with. So I really don't do it within less than an hour. So that's my little tip on that. Now, when you have someone on APRV and the PFR2 ratio is still less than 100 and you're struggling, and the FR2 is still really high, 90 to 100%, you have to keep in the back of your mind that the APRV does not work. You have to think about the next step as well, which is pronation, extracorporeal membrane oxygenation, and high frequency oscillatory ventilation. So these are your next go-to modes of ventilation, or at least for this, at least it's a way to keep the patient and maximize oxygenation and cardiopulmonary output. So just consider that as well, especially the APRV. Don't have that too far at the back of your head. So now we're just going to recap. We spoke about how to maintain oxygenation with P high and along with T high, and then we touched on how to maintain PCO2 with sedation. You want to minimize sedation to allow spontaneous respiratory efforts, and you want to optimize T low if you need to increase the T low to allow for longer time of decompression and wash out the CO2. If that doesn't work, then you may want to reduce your T high. Alrighty, thank you.